So we shall now go on to our last speaker, Dr. SUCHI SMITHA, a private practitioner at Pune, a reputed cornea and refractive surgeon, a great presence in life beyond ophthalmology with her immensely artistic flair. And she is going to dwell on a very important topic, superficial punctate keratitis, differential diagnosis and management. And we are as fresh as we were at 6 p.m., SUCHI SMITHA. So we look forward to hear you.
Thank you so much, ma'am, for that, for the entire session, not just for this opportunity, for all the sessions that you have planned, which have been very helpful for everyone, including myself. Now, after the array of fantastic cases and speakers, we'll be going on to a very basic topic, which we see in a multitude of clinical conditions, including those which were described earlier so nicely. So superficial punctate keratitis is an important topic for a postgraduate because this is a very commonly confusing finding at the slit lamp. It is not a specific finding for a particular disease entity, but it can be found in many conditions, and there are specific patterns in certain eye conditions which help us diagnose and treat this condition, the underlying condition, more effectively. So it consists of discrete scattered punctate lesions in the corneal epithelium. Usually it is the superficial epithelium that is involved. They can be micropunctate or macropunctate, or even up to the extent of a confluent staining. And it is visualized better on fluorescein staining and with other types of dyes. So now, the most common cause why this happens is when there is a strain to the surface epithelium in the form of an infection, inflammation, cell death, trauma. By trauma, I mean either desiccation or even toxic insult to the epithelium. Patient may have foreign body sensation, photophobia, watering, blurry vision, or they may not be symptomatic, like it was discussed earlier by Dr. Paras so nicely in neurotrophic keratitis. So one of the most common entity where we see SPKs or punctate epithelial keratitis is our adenoviral keratoconjunctivitis. That is a viral entity. Though it can be caused by other viral entities, more common is adenoviral. Here we see a bilateral punctate epithelial keratitis towards the end of first week of EKC, and it may present itself up to a maximum up to third week. It is present during the acute stage where patient comes with bilateral watering, chemosis, lid inflammation, lid swelling, and they are symptomatic with discharge, and spontaneously it resolves on its own even without any treatment. The treatment is aimed at symptomatic care. Here we not use steroids for the sake of these punctate keratitis, because our aim is just to help the patient tide over the period, because patient's immunity takes care of the condition. If we use steroids, it has been shown that the viral replication increases and the viral particles can penetrate deeper, and eventually patient may end up with subepithelial forms of keratitis, which can be troublesome eventually, apart from the potential of spread. 1% povidone iodine, that is dilute preparation with or without dexamethasone, has also been tried in literature, but most often we give symptomatic treatment with NSAID, lubricants, and even systemic NSAIDs. Now we need to differentiate this entity from a more deeper lesion, that is the subepithelial keratitis or nummular keratitis or subepithelial infiltrates. It is better not to confuse this condition or call it specifically as subepithelial infiltrates when we see deeper lesions like this in this lower picture. Punctate epithelial keratitis or SPK is actually a superficial lesion which involves the upper epithelial layers because of the damage to the glycocalyx, or because in a dry eye situation or desiccation, or because of swelling in the superficial epithelial cells. These cells take up fluorescein and there will be bulging over the surface. So that is what is the punctate epithelial keratitis, sometimes called punctate epithelial erosions, when the cause is not inflammatory. Now, when the lesion is deeper at the level of deep or basal epithelial cells, or the Bowman's layer, or still deeper in the anterior stromal layer, it can be called as the subepithelial keratitis. Here, the second type of lesion is seen in adenoviral keratoconjunctivitis a bit later in the disease, that is after the second week, and it can come in crops, 2 to 3 crops in over a period of a year or more, rarely, depending upon the severity of the infection, the strain of the infection. Now, this should be treated in a different manner, and in this case, these lesions are readily seen on the slit lamp, unlike the prior lesion, and we don't need fluorescein staining to see subepithelial infiltrates. Here the fluorescein staining is negative, or there can be a negative staining if there is a small bulge in that area because of the swelling of the underlying cells, or there can be some amount of stippling. So basically these two lesions, the level is different. Now, subepithelial infiltrates or nummular keratitis happens in the anterior stroma or the basal epithelial layers, as discussed below. It can be seen, it can be only an inflammation, or there can be a combination of a scar and an inflammation, or sometimes we may be seeing only scars. This can be seen in viral conditions, sometimes even in herpes simplex as well as herpes zoster. So the treatment, if there are peripheral lesions and patient is not symptomatic, then we would not want to treat them unnecessarily, because use of steroids, then we need to taper the steroids slowly. If the lesions are in the center, or if the patient has glare, or they're symptomatic, or they have blurry vision, like some professions where they have to drive at night, or even surgeons or some pilots or something like that, where the vision is very important, then we can treat them with steroids topically. These steroids can be in the form of surface acting steroids if the lesions are mild, or rarely we may be using a stronger steroid in the initial 1 week or 10 days to quickly relieve these spots, and eventually shift to a soft steroid, and eventually shift to a non-steroidal agent like topical cyclosporin or tacrolimus, and maintain this for a few weeks to months, and eventually keep them on patient on follow-up. So as we mentioned earlier, there can be crops of these lesions happening, and subsequent crops become milder, and eventually patient may become symptom-free. So there's another entity which we need to keep in mind, that is the microsporidial punctate epithelial keratitis. The features over here are slightly different. This is a unilateral condition most of the times, and there is a stuck-on appearance of these lesions. They are more prominent, and there is a bulging on the surface of the epithelium wherever the lesion is there. The lesions are coarse and different in shape, and usually small lesions scattered in the cornea. So here the treatment is different, because we need to remove the epithelium, and most of the cases use just lubricants, or some topical antibiotics can be used. Topical like moxifloxacin or topical voriconazole has also been tried. It is a self-limiting condition. There can be lymph node enlargement like in a viral condition, and there can be a mucoid conjunctivitis with follicles or papillary reaction. So the scrapings can be subjected to microscopy, and use KOH and calculus stain. We can find the non-budding spores of the microsporidia. I found this nice image to show the OCT findings and the level of the lesion in the previously discussed situations. The top portion is the adenoviral PEK, or the punctate epithelial keratitis, where the lesion is in the epithelium. There is an irregularity of the epithelium and the bulging of the epithelium. The underlying stroma is normal over here. And whereas the last one is the where the nummular keratitis, where the lesions are in the anterior stroma, where the epithelium is intact, and the middle one is actually a healing microsporidial lesion, where the epithelium has healed and they found larger nummular lesions. Now, other infections like herpes simplex zoster also can cause punctate epithelial keratitis, which join to form more typical lesions like the dendrites. Even the acanthamoeba, we can find this kind of pseudodendrites, which may be initially SPKs. The previous history of contact lens and a prolonged disease course should prompt us to look for these perineural infiltrates in such conditions. Now, Thiggison's SPK is a typical, it's a diagnosis of exclusion in patients after other things are ruled out. Here, the lesion is at the level of all the layers of the epithelium and not the stroma. Though using confocal microscopy, some stromal involvement was found. We find ovoid raised lesions, bilateral. Here the conjunctiva is normal, unlike previous situations. It can happen at any age. Though adults, it is more common, and it can happen over a period of months or years, where recurrent episodes of photophobia and irritation can come. Topical mild steroids, cyclosporin, tacrolimus, lubricants, and BCL have all been tried. Other conditions are toxic, like excess UV light exposure, like in photokeratitis. We find diffuse punctate staining bilaterally, and patient is very symptomatic. Lubricants or patching the eye can be done. Medicamentosa or toxic causes can cause diffuse or lower corneal involvement with the lower fornix involvement. And exposure keratopathy. Here we see that in this case, there was a sty and patient was a computer user not blinking properly. There's a Dellen as well as punctate staining in the inferior nasal area and inferior cornea. So when the inferior 1/3 of the cornea is involved, then we should look for this kind of an exposure. This is a case of lag of thalamus and treat the condition accordingly. Dry eyes can cause staining in the conjunctiva also along with the cornea, unlike in some of the earlier conditions. And so all the cases of dry eyes in severe cases can have SPK-like lesions, but other things would be reduced Schirmer's and reduced TBUT and other findings like filaments and the limbal stem cell clinical features should be looked for. Recurrent erosions can lead to focal staining or focal SPK. We might find underlying typical lesions like in epithelial Bowman disease, like MAP dot dystrophy, and patient will have a morning a symptom waking up, tearing and pain, which kind of subsides later or may last for a few days, or past history of some form of nail injury. If we see any punctate lesion in the superior half or 1/3 of the cornea, we must think of VKC, a foreign body under the palpebral conjunctiva or the subtarsal foreign body should be looked for, where the abrasions can be linear. In SLKC or superior limbic keratoconjunctivitis, we can find staining in the adjacent conjunctiva as well, some filaments and staining in the upper one of the cornea. And also in relation to lid viper syndrome, though the staining is under the lid, there can be some staining in the upper portion of the cornea. And the lower 1/3 of the cornea at the lower margin, we should look at lid disease, entropion here, and the lashes are rubbing on the cornea leading to SPK. These conditions should be treated, otherwise the patient can develop ulcers. Again, lid margin disease, like mentioned earlier, will cause a lower limbal involvement. Contact lenses can give rise to a variety of SPKs. Immune infiltrates in the epithelial layer, multiple fine infiltrates like this can be seen, or there can be a kind of a toxic reaction from prolonged from the detergents which is present in the multipurpose solutions, which when the contact lenses are not being maintained hygienically, or a 3 and 9 o'clock staining which is seen with the RGP lenses because of desiccation in the interpalpebral area when there's an underlying dry eye condition or a poor fit. So this is one entity where there can be a transient staining in the initial time of the contact lens use in the first 4 hours, where the fluorescence gets taken up by the epithelial cells of the cornea and the conjunctiva. That is the SICS or solution-induced corneal staining, especially if patient is topping up the solution each time in situation where there PHMB or polyquad in the solution. So rarely there can be endothelial dysfunction also in SPK when there is, especially when the IOP is on the higher side, we see that SPKs are forming. We should also look at the deeper cornea, treat it with IOP lower agents and hypertonic saline, and until the definitive treatment is performed. Thank you so much.
That was a wonderful talk. We give you 100 out of 100. That's so nice.
Thank you.
And I just have a question for Dr. Merle and even Dr. Praveen. When you're doing a PTK for post-viral SPK scars, how long would you wait for the eye to be quiet before you do this? Dr. Merle?
Yeah, so I think, so basically you need to ensure that one, the patient has got no cellularity associated with the lesions. And if there's cellularity, obviously there's still some activity going on and you wouldn't want to, do a PTK at that point of time. So as far as how long, usually we've been putting patients on low potent steroids, doing a very, very slow taper if they're symptomatic, and then also putting them on topical cyclosporin, and then observing them. And if then, even after using this medication for at least 3 months to 6 months, then probably proceed with PTK. I don't know if Praveen has a different protocol, but that's what I've been following.
Yeah, somebody only SEIs of steroids, only if then the visual axis leading to light scatter. And we've also done PRK for patients who've had previous SEIs as well. But I think 3 months off steroids, I haven't seen a problem with that.
Any other question you would like to ask, SUCHI?
No, I think
many times.
Presentation quite brilliant actually, from the point of view of looking at patterns and looking at levels and also trying to decipher all of that. So very, very nice talk for postgraduate students. Thank you.
Thank you, sir. And many times these seemingly looking scars will have some activity, and if we start steroids, they tend to disappear. So, yeah.
So, and then use of tacrolimus in thygosins, how long would you keep them on this? Dr. Himanshu?
I'm not a great fan of Thygison, by the way. I mean, I feel it's sometimes overdiagnosed, and where previously we didn't know many of pathology. That's why Thygison was there. But still, having said that, whenever we treat them with anti-inflammatory molecules, they do respond. And unfortunately, there's no golden rule for how long you need to keep them. Any anti-inflammatory will have its own side effect and its own issues. So you have to discontinue in between. Is there a golden rule to discontinue? How fast? How soon? No, I don't think. Everybody has their whimsies, and we all, in absence of evidence, we follow our whimsies. So we do follow with the low-dose steroid, continue them for a little longer time, stop them after a couple of months and see how they behave. If they come back, we restart. But I'm really not sure if there is any definite answer to that. If anybody else has, I would be really happy to know about that.
Anybody has to add anything before I go on to my concluding remarks?
I just want to say, I mean, typically, we tend to have sessions that are themed on particular diseases and topics, like infections and refractive surgery and so many other things. But then it's very rare to have a compendium of such rare topics on the cornea, but something that we all come across so much. So I have to congratulate Chitra for thinking of putting all of these together and actually inviting such a fantastic panel as well as a fantastic group of speakers. So all high hats off to you, Chitra. Well done.
I think it's totally hats off to the expert panel, my great co-moderator, and of course, every single speaker. I mean, I wish I could send a mail 200 times to everybody that please listen to this on website, even if you have missed today's talk. And I'm really grateful for making it such a successful webinar. Of course, I need to thank my own ARC team for being a backbone of support for me. Thanks to Mr. Kripal and his entire AIOS team. Thanks to Sai and Manjula from Numerotech for always being there. All those mails which are shot to you and fill your inboxes are thanks to them. And of course, we all know, you must be knowing Dr. Anand Sethi by now, how meticulous he is, and his webinar team. My special thanks to them. And I think I really need to owe my thanks to Sun Pharma for sponsoring and taking such special interest in the PG training program in this recent past. And finally, and most importantly, I think I really need to thank our attendees, because they only energize me and give me the passion to keep coming back to you all again and again with more and more webinars. Thank you, one and all. Thank you very much. Thanks, Praveen. Thank you all. Thanks a lot. A huge clap.